At the Global Liver Institute, we believe it all starts with a patient. So what happens when a patient, a liver patient no less, one of the 500 million people living with conditions that often go undiagnosed, untreated, or misdiagnosed, mistreated, and stigmatized, brings the challenges of liver patients front and center? And what happens when a patient then leads a discussion with world experts in policy, research, clinical care, and wellness on ways to overcome these challenges? Let's find out today on GLI Live. Hello and welcome. This is a very special, a unique crossover episode of GLI Live meets Surfing the NASH Tsunami. So if you know that name, as Trevor Noah likes to say, if you don't know, now you know. The host of that incredible podcast is Roger Green, and he is my guest today. Welcome, Roger.
Thank you, Donna. This feels like turning the table since you've been my guest so many times.
It is, and until recently, though, to do your lovely podcast, you haven't had to get dressed and really worry about your film or your frame, but you've been sort of sneaking in screenshots of people lately, so I'm gonna have to make note of that.
We've actually gone live audience as well, so actually not by invitation. At this point, if you want to come to our live audience, you simply have to send us a note saying you want to go to our live audience, and we'll send you a link, and you can come on in. People have been doing that. So yes.
So I have had the privilege of being a guest on your show several times. One of your surfers, as you call them. For folks who haven't had the opportunity to listen to the Surfing the NASH Tsunami podcast hosted by Roger Green, who is managing principal of Hep Dynamics and executive producer, as well as host of this show. Roger, why don't you tell our watchers and our listeners about the podcast?
Well, first of all, I love the podcast. It's the most fun I've had at work in probably decades. Little background, I ran a pharmaceutical marketing research firm for about 30 years. I burned out on marketing research. I was trying to look for something next to do. About the time that happened, I got invited to NASH 2019. I gave a speech. I said a lot of things I thought would be controversial and unpopular. I was half right. They were controversial, but people said, gee, why don't you stick around and talk to us more? So that led to a conversation with Dr. Stephen Harrison in March of 2020, about the time the world shut down, about how to educate investors and drug developers about the idea that they could keep doing their clinical trials. We decided to do a 4-episode podcast with 4 distinct titles. And after the first episode and after the 3rd episode, patients wrote us in with questions that suggested that they were living with tremendous fear and no decent knowledge about their disease, or they were getting advice from Dr. Google, which is really the same thing. And we decided to keep going. We will drop our 103rd live episode, our 103rd episode tonight. We drop Wednesday nights at 10 o'clock Eastern time. I think Donna's been a guest for about 15 or 18 of those at this point. I don't have the exact count up to date. And we get 1,000 downloads a week. We've got regular listeners in 28 countries that we can identify so far. In fact, we regularly make the top 250 medical podcast list in 10 countries. And our biggest audience relative to size is Macedonia. I can't explain that. Okay.
Well, we welcome Macedonia.
Welcome, Macedonia.
Our collective listeners and watchers. So really, we were on a very similar path. As they say, out of crisis comes opportunity. And the pandemic launched GLI Live as we were seeking a way to communicate, to stay connected with our patients and various stakeholders in real time, to be topical, to be fresh with them. And we didn't anticipate that it would be something that would become a major part of the organization and to continue on these many episodes later. And so, tell us more about what attracted you to NASH. So many of us in the liver health field, certainly as liver patients. We feel like, we don't get any attention, we don't get any respect. It's been underserved, undertreated, under recognized for so long. But you saw something in us. You saw something in this field that was worth your time and attention. So tell us more about what you saw, both in the need and in the opportunity in NASH.
Well, okay. I can speak to the need on two levels. Number one is the success that our respective podcasts have had suggests that we were living in a desert and we've provided oases.
Mm-hmm.
And the lesson I learned once we started, I'll get back to why in a second, why liver. But the lesson I learned once we started was how many people from how many diverse backgrounds were looking for information, and we're looking for a way to touch a larger community and feel part of a larger community, something I think you folks have done a fantastic job with day in, day out. But, when we went live audience, one of the first people who signed on, we asked why. He said, well, I've had fatty liver disease for 10 years. I'd like to learn something about it every week. And so I think there's the need. Why liver? Liver is a really important organ and tremendously underappreciated. They taught me back in business school that people look at what's inspected, not what's expected. And the fact that it's been so hard to get a metric for liver disease means that we don't really know when it's the liver that's causing the problem or not. Okay. My background's in statistics. One of the things they do is they teach you what a decent error margin is, or a level of, or an R square or a predictive result. But if you get a R square of 0.5, which is considered really good for a lot of things, it means that half the time you have no clue what's making it happen. And I think the liver sits behind a lot of that. The people can't predict diabetes, coronary disease, extra hepatic cancers, because we don't understand enough about what the liver is doing or how to measure it.
Right.
And so, and when I went to NASH 2019, the only thing people were focusing on was how do we get a one-level drop in fibrosis so we can get a drug approved, without a tremendous amount of discussion that was intelligible to me about what do we know that's going to help us do that better. So I'm a big fan of dynamic systems. I thought maybe I could shine a light on a little of this with help of friends, and that's how we got here.
As I measure success or at least progress in this field, you coming into it with your particular background in statistics, in market research, I feel is a measure of progress, because you bring in a different perspective, certainly a different skill set, but also a different network of people, of investors and those from the financial community who are only starting really to pay serious attention to liver health and solutions for liver health. Certainly the success of hepatitis C drug, accelerated that in a big way, but there's, acceleration, and then there's something that's sustainable. And to make it sustainable, I think there really needs to be a lot more and deeper education of the investor and financial community about the entire landscape of liver health, but NASH in particular, given its complexity. So I was really excited to welcome you and your expertise and your network, to this fight, to this effort. Can you tell us about, what you have heard, or the particular questions that come from the investor, the financial, the market research quarter of this? Often in this show, we're answering questions from patients and some physicians, but you get an entirely different set of questions that come across our path. And so, help elevate some of those so we understand.
Well, so these folks are result oriented, but in a very specific sense, which is, can I predict what will and won't succeed commercially? So the stigma that the field deals with, and we'll be dealing with for another year or two probably, is why haven't we gotten any drugs approved? Because really, drugs are the big commercial driver, right? Approved pharmaceuticals and biologics. When one novel entity gets approved, those rules will change. What I try to educate people on, no, what I educate people on, I think I do a better job than just trying, is the idea that in some ways this has been a blessing, that we've learned so much about this disease, and that what we've learned has gotten so much more attention than it would have if all we were doing were studies on little nits and gnats about the one or two drugs that are approved that it would be great to have, but are not exceptionally effective. I think the breadth of the understanding folks have about this disease is tremendous. And what I counsel people is fundamentally, we're now waiting for the dam to burst. And when the dam bursts, the pace at which we will be able to improve diagnostics and treatment is really going to be compelling. People remember for how long it took after that we were looking at Hep C to get to the antivirals. People forget for how long after Nixon declared his war on cancer in 1969 it took to get the decent cancer drugs. We're really close here. We're really close.
I agree. I've seen and certainly felt the progress. Certainly after the latest liver meeting. The theme for this month at GLI is joy, which is one of the reasons why you're a guest, because speaking to you is one of the things that brings me joy. So we reached out, but it sounds like there are reasons for joy in I hate to make the pun in Nashville, that there are reasons for joy in the field, or at least some optimism. What are some of those things?
Okay. Great question. And I will admit we've used Nashville shamelessly. So I think your modesty is compelling on this subject. First of all, diagnostics. Okay. And diagnostics really means two different things. It means the diagnostics necessary to test and get drugs approved. And then it means once you have drugs approved, there are going to be probably billions of patients with some level of disease. And we're going to need to have a system to understand who needs to be treated urgently and what that means and who should rely on self-care. So the movement beyond the biopsy, which has come from a lot of places, but GLI certainly has been a major one, is of tremendous importance. In 2020 at NASH Tech, Stephen Harrison did a presentation on the low level of reliability when two different world-class readers would read the same biopsy, or when the same world-class reader would read it twice, 6 months apart. And I was compelled to comment that my marketing research firm would have gotten fired for anything we ever did with that level of reliability, yet it's what we use, right? But the advances that have been made, I think MRE is a huge area for advance. We've learned things about many different tests, about machine-generated tests, about liquid biopsies, that start to tell us that there are tests that we can use reliably to predict what's going on in the body. So that's number one. And in fact, I think there's some receptiveness. You hear signs of receptiveness from the regulatory agencies. And I'm of the hope that the patient-focused drug development day that you did in November will have a lot of impact on that, because I think it ratchets up urgency when regulatory agencies understand the urgency that patients feel. So we've got better tests. Now the question is, are we going to be willing to use them readily enough? Number one. Number two is, frankly, we've got better drugs. We've got drugs that make more sense, that have shown more promising results in early phases as we go through development. And number three is we're getting more complex understanding of the disease. So, for example, there's a drug that Novo Nordisk markets today called Smaglite for diabetes and obesity that's been tested in NASH. And the one thing it has not been able to do is to produce a decrease in fibrosis level. Well, 2 years ago, people would say, gosh, that's the kiss of death. They're not reducing F1 or not reducing fibrosis level. Now there's a question that goes, well, gee, some patients might do fine if you simply maintain their fibrosis level so they never progress. That's based on how much more we understand about how the disease works. And then finally, the work that's done in genomics and pharmacogenomics, we know a lot more about why people get the disease, and ultimately we'll be able to do a much better job of targeting it.
I think those are all exciting things. I think those are many things that I've said for consistently for years. One of which is that we would most likely need to have multiple drugs that attacked multiple mechanisms of actions. You're already in a patient population that was polypharmacy, and so we needed to be sensitive to that. And that, non-invasive diagnostics were the only way we were going to scale, certainly even screening and diagnosis, but management and measurement of treatment response for millions of patients. We were never going to be able to meet the patient needs in NASH or in the US or around the world if we didn't get away from biopsy. It was by definition, literally by definition, a rate limiting factor of the field. And so,
and a bad measure of food, right? There's the old line about the restaurant, bad food in such small portions.
Exactly.
That would be biopsy.
Exactly. As a patient who's had 6 liver biopsies, the thought that even where tests stood 2 years ago or more when we started our Beyond the Biopsy campaign, I could have taken all of the tests, less expensively, with less, risk to myself. And I think putting them all the information together got more information than a biopsy. And, today, seeing the sort of the winnowing down as tests have gone head to head in a way that I've rarely ever seen in any other area, to really come out with such a great understanding of, which test for what when, and the clarity that is very soon to come in terms of non-invasive diagnostic use is exciting. It's patient-centric at its best. It's innovation in its truest sense, not just something new, but something new that makes a difference. And so I think that this field is one of the most dynamic, which I guess is why you named your group Have Dynamics, but it's truly one of the most dynamic in science today, and the most productive. There's a lot of wonderful work going on in other disease states, but very few is consistently bearing as much fruit and coming closer and closer to the goal as I see it here in hepatology and in NASH specifically.
I completely agree with that. And if we're talking about joy, I'd like to talk about 2 more sources of joy.
Please.
One interesting but speculative, and the other interesting but requiring a lot of time really to meld. Here's the first one. Arrowhead Pharmaceuticals dropped a poster, late-breaking poster at AASLD that talked about an RNAi-based therapy in phase 1 targeting one of the key genes that's implicated. Michael Charton came on our podcast, and it was episode 56, if you want to listen, and talked about how that might be the beginning of looking for a vaccine for NASH, which I thought was fascinating. And then the next week, Novo Nordisk buys Dicerna for $3.9 billion. And what is Dicerna but an RNA-based vaccine and therapeutics company? So I think that's tremendously exciting and really promising for the future for a whole bunch of patients. Number one. Number 2,
can I make a statement before you go on?
Sure.
My husband and I both drove separately to Pennsylvania for Thanksgiving, and we met up. But we drove up at different times, and independently of each other, we both decided that the best use of our time for a little over 3 hours was to listen and catch up on our back episodes of the NASH Tsunami podcast. So we both arrived in Pennsylvania, eager to share with each other what we had learned by listening to your podcast. So I had that, and it is fascinating.
Thank you, and I need to use that in an ad somehow. We'll figure out what to do with it, but thank you so much. That's great.
And for the listeners and watchers, my husband is a geneticist with an expertise in lipid metabolism. So the audience for who benefits from the podcast is broad, at least by the definition of the 2 of us.
Yeah, I think that's right. And then you take that over to the Seattle Seahawks fan who watches a live episode every week because he had fatty liver for 10 years, and you really have spanned the entire spectrum, haven't you?
There you go.
Here's the second point. This disease is in the process of landing on the world like a ton of bricks.
Mhm.
Okay. They're predicting anywhere from a doubling to a quadrupling of cirrhosis patients in the next 9 years in all major countries. We have no way to treat everybody we've got right now. Forget everybody that we're going to have. But two events, two publications in the last month have suggested that we're finally starting to comprehend the scope of what needs to get done from very different places. One, the American Gastroenterological Association, a word I can never say properly.
AGA. That's
AGA.
why everybody calls it AGA.
I'll do that from here on out. AGA convened a group of specialists, multiple specialists, but notably not mostly hepatologists, although there were hepatologists involved, to take a look at what do we need to do to organize to treat this pandemic, and how do we create a clinical care pathway that encompasses all specialties so that we don't have everybody flooding to their hepatologists if there aren't enough hepatologists to handle the flood, but a systematic approach to all that. They published 2 articles on that. The second one came out about 2 months ago, I guess, in Gastroenterology Journal on clinical care pathways. Great reads, a fantastic piece of work, and in one way, the first integrated look we've taken at this disease. Here's the other one. This published about a month ago. Jeff Lazarus, who does heroic work in so many areas, has gotten involved in NASH and convened a process with 218 folks from 95 countries.
Yes,
in a three-stage.
We were at least 3 of the folks out of the 218, and helped with that. It helped with that initiative. So.
Yeah, in a 3-stage Delphi model, where we now have a global public health agenda for NAFLD. That so fundamentally, we have a worldwide recognition that this has to be dealt with. At least within the States, we have a pathway to do that. One of the things that Jeff said that's noteworthy is that they evaluated as many countries as they could on their preparedness for the NASH pandemic. No country scored higher than 50.
Right. That was the same result that we found in our U.S. and our NASH Council, and when we came up last December, this time last year, with the U.S. NASH Action Plan, with the country's first national NASH Action Plan. It really was about setting a framework and an assignment for each stakeholder to take apart, recognizing that we were going to need everybody on board, from medical societies to patient advocacy organizations, to be able to address this fully. And so, we're so excited that, AGA took up, an element from that plan in moving their care pathway forward. Organizations like Jeff, took, a step forward. We'll really be excited to put out that full 1-year report card on the action plan. And there's so many more actions that can be taken. But I think in breaking it down into the essential elements, rather than just this overwhelming problem with a sense of doom, it has made it easier for a host of different organizations and entities to take a step forward to address the problem. Agreed.
Shameless plug for the podcast. Our episode with Jeff on the global agenda drops at 10 o'clock tonight.
Fantastic.
So people want to hear that. And he tells a story about the way the entire Nature Reviews publication family and all the different journals converged around this issue once they saw what was developed. So I think as we shine light on things, as you shine light on things, as Jeff shines light on things, as other organizations, folks will cluster to it because they'll understand what needs to be done and they'll see how they can play a part. I think that's a really important thing. So that. Number 2, when you have the 1-year plan in place, I'm hoping you or Andrew or both of you will come on podcast and walk us through it and what we've learned and what's gotten better and what still needs to improve.
Happy to.
Good.
One of us. That's the beauty of an expanding team. That There is somebody who can represent. It has been amazing to attempt to scale to meet the need that we see in NASH, and to be able to be simultaneously, as the team has often been, in events on NASH in Brussels and Boston and, in Boise, Idaho, through some mechanism simultaneously. And, that's what this effort requires. But to be able to do that is really exciting.
Mm-hmm. Yeah, I think your people are fantastic, and watching what you've been doing to grow has been nothing short of remarkable, frankly. You want to talk about not-for-profit entrepreneurship at its best. I think what you've done with this institute has been exceptional.
Thank you. So, the pandemic certainly, it gave birth to both of our programs. So, we can count that as a major silver lining. But it's been an opportunity for so many to learn so much. I had a hospital board meeting this morning, and I recognize how much we have changed, how much we've learned, how much will continue to be different because of the pandemic. What have you learned coming out of the pandemic? What will be forever different in how you do things because of COVID-19 and because of just the last 2 years?
Well, how I do things, probably not so much. How things are done differently, since I do this podcast, how things are done differently around NASH. Very, very different question. I think this pandemic revealed, in all diseases, but particularly germane to this one, the importance of decentralizing clinical trials. That when we had patients who couldn't get to bricks and mortar locations 60, 70 miles away for a visit, you had to figure out how to get the trial out to the patient. Now, the first step was to figure out how to do that working within the structures of specialty that existed. But we're not far away in liver from getting to a place where trials can decentralize to the degree where any primary care doctor who has trial competence can decentralize to her or his patients in remote locations, at which point the pool of patients that can come into trials expands dramatically, which is important because we look at 75, 80% screen fail rates on the studies we do, and the demand we have for patients over the next 3 years outstrips what we'd be able to provide for liver trials if we don't find a way to do it better. So decentralization, I think, is pivotal, number one. Number two, to the degree that we're pushing agencies to go beyond the biopsy, that will have the same effect of making it easier to process meaningful data. Even simply going from semi-quantitative analysis to AI will make it easier to systematize and understand results faster. And movement beyond biopsy altogether will dramatically increase trial throughput. So I think those are major areas. The other thing, I guess, is the pandemic has given birth to and technical progress both, to a bunch of apps, right? So there are now phenomenally successful apps about weight loss. I've got 3 clients right now who are trying to figure out how to get digital prescription apps out on NASH. So as people get more tapped into doing things via app, they will have more different ways to get support for doing it. And that will empower patients to take better care of themselves, because lots of people want to and don't quite know how.
I think that's absolutely true. I think that whether it's decentralized trials or apps, and the non-invasive technologies that need to go along with those, they all have the same premise of bringing medicine or research to people, rather than having the expectation that people are going to go to research. And I think that that's very important. It may be even more important, or quite high in importance, particularly for liver patients, for NASH patients, where the disease at its early stages does not have a lot of overt symptoms. And so there are a lot of people who are walking around, undiagnosed and maybe not really feeling the effects of the disease quite yet. And so there's not a lot driving them into care or into trials. And so we need to make it as easy as possible, reduce all the barriers, reduce the friction, go to where people are, go to where people of diverse backgrounds are, so that we have the possibility of really answering the full set of questions that are arising in NASH. We already know, even just with the populations that are included in research, how different the paths of progression is, or how heterogeneous the combination of factors and the impact of inflammation or fibrosis are in different people. And we can only know more better when we have more people and a more diverse set of people in it, and so that the drugs and treatments and therapies that emerge are truly effective, and we also don't miss out on some that may be effective in particular populations. And if those aren't powered, then we may miss out on some things that would be very valuable to have on the market. And so I think this element of bringing research to people is great from an equity standpoint, great from a patient-centric standpoint, but I think it is really important and improves the field altogether.
Yes, I think that's right. And I'm going to go slightly off in a different direction, but I think it matters. So one of the other areas where research I think will turn really compelling is around microbiome.
Mm-hmm.
Because Scott Friedman made a point recently on a podcast that wasn't his. It came from an infectious disease doctor he works with, that it's reasonable to think of NASH as a environmental disease.
Mm-hmm.
That if you think about it, we've had the same genes for thousands of years,
mm-hmm.
and we haven't had this kind of phenomenon for thousands of
Mm-hmm.
years. So you ask what's happened in the last 30, 35 years that makes this so much more of a disease. Scott's answer from the gentleman who had been talking with him about this was it's diet, right? We eat a lot more worse food. And if we got people to eat better, that would be helpful. Jeff Lazarus, same question. Again, podcast drops tonight, said diet matters, but by the way, so does sedentary lifestyle. So one of their sustainable development goals is getting spaces for people to walk and exercise and work out in their communities, so that when folks want to actually do a better job of taking care of their physical conditioning, they don't need to drive to a gym and buy a gym membership, or, Louise Campbell talks about lifting soup cans in your own kitchen and doing squats at the counter, but that's not a sustainable development goal either. But if we think about this more widely, if we think about a diet, the soda bans and some of the fast food stuff that they're doing in some of the markets, and we think about creating better opportunities to exercise and live a less sedentary lifestyle, that also I think will have a real impact.
I agree. So it sounds like there are fascinating things that people can hear on every episode of the Surfing the NASH Tsunami podcast.
Particularly when Donna Cryer shows up, yeah.
Including tonight, and we will put the link in the show notes to this. And I will simply thank you, Roger. And I would say happy holidays, but I know I'll see you before all of the various holidays that we all celebrate are through. So I'll just say thank you for our conversation today.
And Donna, thanks for having me. And, you're an inspiration to all of us. The organization is fantastic. And you personally are an inspiration and role model to so many people that I'm delighted you invited me to join. And everything you do with us is a gift. So thanks.
Thank you.
Please be sure to like this video, subscribe, and share your thoughts and suggestions in the comments below. Join us weekly on Wednesdays at noon Eastern Time for more episodes of GLI Live. Check out our website, globalliver.org, and follow us on social media to learn more about the Global Liver Institute and stay up to date with the latest in liver health. Until next time, stay safe, stay well, and stay connected.